When you say it's my opinion, it angers me. Because to say it's my opinion is to say that pathology is not science. To say it's my opinion that if another person were to review these objective slides, they wouldn't get the same conclusions. I tell you one thing, I'm trying to educate the public. You can accept it or keep it moving. But don't insult me by telling me my conclusions or opinion and not based on pathological facts. Then I want to challenge that statement because I'm committed to educating the public. This case here that I'm about to show, a 34-year-old lady simply begged by her primary care doctor to get bariatric surgery when she was only, maybe 100 pounds overweight, but still very healthy, otherwise no diabetes, no high blood pressure, but simply looked at her weight to insist that she got bariatric surgery. Well, she did just that. So she presented with bariatric surgery and had complications from that surgery. And the complication included ischemic bowel, which I'm going to show you, dead bowel. And she presented to her, the surgeon, several days after the surgery, complaining about severe pain and not getting better. And is eventually presented to the ER, collapsed and died, essentially becoming brain dead. We got to stop this, people. And I'm going to show you these slides that is not Jackson Gates' opinion. It's called pathology. And it's unfortunate that the public don't realize what we do as pathologists. It's really unfortunate that we are the doctor's doctor. We tell the doctors what happened. So in this case, I just want to simply encourage all, don't insult me. I have 30 years in this business and I know what I'm doing. If I didn't, I think someone would be able to say it by now. And I welcome any challenge. You can look at all of my posts. They will show that I welcome anybody to challenge my diagnosis. So these first few slides, I always take lung section, although this was a second opinion. So I was still able to get some tissue that was collected from the previous dissected organs and able to make a diagnosis. And you can see here is one image I want to kind of zoom in on, showing that ultimately this was a clotted vein showing extensive hemorrhage. The portal vein was clotted, as well as the superior mesenteric vein. I suspect it was clotted as well, because there was extensive ischemia involving the liver and the intestines, which are usually around that superior mesenteric and superior mesenteric flow of blood flow. So anyway, I want to kind of go into the specifics. It's going to be a very long video, but I'll probably have to break it up. I just want to show you that science is science when it comes to pathology and medicine. Thank you. No one should be subject to this sort of torment from an elective surgery, not an emergency surgery, but an elective surgery. And so what I want to show, I've selected some of the slides that I had demonstrated earlier to show, and I'm going to show you a coronary artery. I'm going to show you a normal heart muscle. I'm going to show you a lung tissue that has an inflamed clot. You can even say that talk about a little bit about the hematology, showing a leukemoid reaction from infection and the clot. I'm going to show you liver tissue that's showing a portal vein thrombus in it. You can see it from even the slide. Moving forward, I'm going to show you liver tissue that shows extensive necrosis and hemorrhage. You can see that from the slide. Even from the growth slide here, I'm going to show you more ischemic liver tissue with more clot in it. You can see a little clot there on the left of the image there, and even hemorrhage in that liver. The next slide I'm going to show would be thyroid tissue showing multinodular goiter, a random thyroid tissue, toxic goiter. And then I'm going to show the clot in fat with extensive hemorrhage and necrosis. Then I'm going to show you more hemorrhage in fat tissue. And then necrosis, ischemic small bowel, full thickness necrosis of the bowel consistent with gangrene from lack of blood supply. And then I'm going to show you more of the gangrenous small bowel. Show you features of necrotic cerebellum, completely necrotic cerebellum. I haven't seen one like this in a long time, where there is no residual neurons, and even more necrotic brain from the final slide. No neurons, completely necrotic brain tissue. Very incompatible, suffering unnecessarily. When a simple CT scan to confirm that the person indeed needed emergency surgery to remove or at least try to rescue her from these clotting phenomenon. And I'm sure I could tell that some of it, even when I looked at the abdominal wall, there was some hemorrhage. I know that the surgeon, I can't wait to see the surgical note, knew that he was into some sort of difficulty with this person clotting. And even in knowing that this person had a history of forming clots. But I'd like to see now if the surgeon even did a pre-op workup to see if she had to confirm whether or not she indeed had some sort of clotting abnormality. But these are important to do before you have anyone do elective surgery. Make sure they do screening labs on you. Pre-op lab is what we call, to make sure that they can get you off the table. But beyond that, getting you off the table is to make sure you can survive the surgery. So I'm going to start showing these slides, and hopefully I'll go real fast because this is going to be a long video. Thank you. So we will begin by showing you this coronary artery, and I'm going to just peruse around first. You can see that there's some mild atheromatous or moderate, actually, atheromatous plaque material, but all develop eventually some sort of a plaque over a lifetime, But this is obviously early forming of plaque, and obviously there was some inflammation going through the wall from her being septic. But other than that, the lumen was very widely patent, and that's just a float of fat tissue there in the lumen, but that's not real. So we're going to go to the next slide to show you the myocardium. So we're showing a myocardium or heart tissue here, and you can see that there is no evidence of ischemic changes or any kind of hypertensive disease of this myocardium. And I'm going to go down just to kind of give you a closer view of the myocardial cells themselves, and you can see they're very healthy and normal appearing. So there was no evidence of a heart disease, at least, from seeing this myocardium. Very normal, healthy looking myocardial sites or cardiac muscle cells. So we're going to go to the next slide. Here's a section of lung. There are normal appearing lungs here, a little congested. And I wanted to show you that clot, if I can peruse around real quickly, to show you a clot. I should have highlighted where that clot was going to be, because this is fairly normal appearing lung tissue, a little vascular congestion. But I wanted to show you that clot if I can get to it before I run out of my video here. I know that's out of focus, but when I get to what I'm looking for, I'll put it back in focus here. Because I remember I was telling you, pathologists, when we view slides, we go in and out of focus just to see, the whole picture of the cells. And let me see. I'm sorry that I'm going. Didn't mean to have this much. And it was a very small blood vessel, or intermediate sized blood vessel, that showed an inflamed clot. And I'm going to pause the video because I don't want to just keep on going around, because it was just focal. But I'm going to pause the video. So here is that clot. You can see the fibrin deposits in it, and you can see even the inflammatory cells to know that the white blood cells were very high in this person that not only has a fibrin clot in it, but also a leukemoid sort of reaction. Okay, we're going to go on to the next slide. Now here is the liver tissue, but I want to peruse over to this portal vein here. Let me see if I can find it real quickly, just to convince to you that that is indeed a clot in that vein. Let me keep on moving over, and it's going to come into view, and it's going to be very clear that this is a portal vein. Okay, here's the vein, and there is the clot. It's an organized clot, inflamed thromboembolic clot. That's occupying most of that portal vein there. We're going to go to the next slide. Let me see if I can go. I can't go to a lower power. Lower power. But you can see that that's an indeed clot in that vein there. A large, sizable clot. And then, I wanted to keep on this slide just to show you that that's real, because you can see that the adjacent liver tissue is ischemic, necrotic. There is normal appearing liver tissue at the rim there. So we go down there. That's what normal liver tissue would have looked like. And then you can see that these are shadowy necrotic liver tissue with abscess and inflammatory detritus around it. And you can see some recent hemorrhage there in the liver, all compatible with this, with the ischemic changes from the liver not getting blood supply for adequate, and then there's some inflammation in the portal triads. Okay, so we're going to go to the next slide. And I think this is just more liver tissue that was extremely ischemic, hemorrhagic, and I think it also had a clot in it. But you can see these are all dead liver cells in a person that had a clotted portal vein. And I think that the mesenteric was also clotted, but anyway. So you can see extensive recent hemorrhage and necrosis in this liver tissue. I'm going to go over to the next slide. And there is some significant inflammation in that portal triad. So maybe a little hepatitis even prior to the surgery. More liver tissue. I'm not sure why I'm showing so much liver tissue here. But you can see it's the same story, necrosis, and extensive recent hemorrhage. Definitely inflammation in those portal triads. So a little chronic hepatitis there. And there was a little fatty change too, moderate fatty change. And it goes with her obesity. Let's see. Those are large bile ducts. Alrighty. So this liver was taking a beating. And I don't think this was just something that could not have been detected clinically, even perhaps during surgery. Because this lady died quite rarely shortly after surgery. Quickly after surgery, a few days after surgery. And I just wanted to show you this thyroid. The random thyroid showing a little hyperplasia of the thyroid follicles. And if I can keep on perusing around, I want to kind of show you the nodular follicular nature of the, there is some inflammation in this thing too. But there is a little toxic thyroid gland there. We get more into it, variable size of follicles there. And some obviously showing hyperplastic changes. I'm just going to peruse around because I thought this was quite neat to see, even from a random thyroid tissue, that there is some evidence of hyperplasia and inflammation of this thyroid gland, which has to be correlated with the clinical. You have to look at thyroid function tests to see if this was some sort of toxic nodular goiter. Okay, but I just wanted to show you that if there's a little inflammation now. I know we had some inflammation in this thing too, little lymphocytic aggregates. So you think about some sort of a chronic thyroid disease as well, which again should have been a part of the clinical evaluation. So we're going to go over to the next case. Our next slide. Then more hemorrhage. This is in the fat tissue. You can see some necrosis in some of that fat tissue. Extensive recent hemorrhage in the fat tissue. And this is possibly around some sort of large vein, mesenteric vein. And I'm suggesting that it's probably superior mesenteric vein, given the nature of involvement of small bowel ischemic necrosis. And there's more fat with hemorrhage in it. Extensive recent hemorrhage in fat tissue. This soft tissue, this fat tissue was taken from the mesentery of the intestine. And let's see if I can keep on moving on. And let's see, just kind of show you the fact that this is all ischemic and necrotic bowel tissue. If I can go to show you the villiform nature of the small bowel. See the villi, all necrotic, shadowy, ghost-like. and obviously showing extensive hemorrhage in the wall. If I can just peruse around. Now, this is all hemorrhage and necrosis in that small bowel. So this would be full thickness necrosis, ischemic gangrene of the small bowel. And that again goes with superior mesenteric flow of blood. More of the same, necrotic bowel. You can see more villi there and some residual crypt glands there, but very necrotic, very extensively hemorrhagic, all compatible with the ischemic gangrene of the small bowel. This is evidence. This is not opinion. Anyone who know about pathology can confirm that this is ischemic bowel. It's not opinion. And here is cerebellum. Complete. There are some residual neurons, but most of it was gone. I mean, there's dropout of neuron in this area right here. There's no neuron right here. So you can see that there's some residual necrotic red neuron, but then then there's also dropout or complete absence of neurons here. This is cerebellum, necrotic cerebellum. And the person was clinically brain dead. More necrotic brain tissue, almost near absence of neurons. All right. Thank you for viewing the video. But again, I show this to show it's not Jackson Gates' opinion. This stuff is based in science, not opinion. That's what pathology is. It's the science of medicine. You can't understand medicine without understanding pathology. Thank you.